Good morning, everyone. Good morning, everyone. Excellent. I'm Andrew Sollinger. I'm the CEO and publisher of Foreign Policy Magazine, and welcome to From Plans to Action, Advancing Cancer Control and Sustaining Innovation in an NCD Era. That's a long title and a mouthful. So in plain English for me, we're talking about one of the most pressing global health challenges of our time, which is cancer, and how every country, regardless of income level, is facing issues and grappling with how to strengthen prevention, diagnosis, treatment, and palliative care. And many have developed national cancer control plans, and that's what we're going to talk about today. Still, there are persistent gaps in financing, workforce capacity, and policy integration that are holding back some of these issues, and even though there's science and will to move forward. So we're going to talk about how to overcome that today. We're going to hear from global health leaders and country experts and focus on implementation. We're going to talk squarely about turning policy into action, embedding innovation sustainably, and making sure that equity remains at the center of this effort. I'd like to thank the World Health Summit for helping us convene this, and to Pfizer for pulling this program together. And I want to thank all of you for joining us. It's a very important discussion. We're very pleased to have you here. We are, of course, recording this as well, so I thank those who are watching online also. One other thing I wanted to mention, so a lot of people ask me, why FP? What is Foreign Policy Magazine doing here? Don't you guys focus on geopolitics? And that's a very good question, but there's a very straightforward answer. Especially since the pandemic, it's very clear that health policy is foreign policy. Health security equals national security, it equals economic security, and often these issues, like those that we're discussing today, they know no borders, no politics, no elections. They're very common, and we can work together to solve those issues, unlike how we worked 5 years or so ago, and will need to work again. So it's very important to FP. So what I'd like to do is have us all, over the course of the next hour and a half, we're going to be hearing from a lot of really interesting speakers. I'm so pleased and happy with the lineup that we've pulled together today. But let's start with a macro view of where the global effort stands and what it takes to translate this ambition into real impact. So I'd like to invite Dr. Cary Adams, Chief Executive Officer of the Union for International Cancer Control, the UICC, to join me on stage. Dr. Cary. So these microphones will come right under our chin. Can you all hear us?
Can you hear me? Okay.
Most importantly, can you hear Dr. Cary? That's really what we want to know. Okay, let's kick right in. Earlier this year, the UICC hosted the Cancer Planners Forum. That's in partnership with the WHO, the IRAC, the IAEA, and members of the International Cancer Control Partnership. And you brought together representatives from 40 countries. Mm-hmm. Can you tell us a little bit about the genesis of that and the goals of the forum, what you were trying to achieve?
Yes, sure. So this actually started as a conversation the year before, so last year. And it was a conversation about how we help national cancer control planning take place at a national level, and particularly national cancer control planners, who tend to be individuals working within the health ministry. And their responsibility is to write, to implement, oversee, report on national cancer control plans. And we were trying to work out how we could get them to start thinking further ahead with regard to their planning on new technologies, maybe, to think about the AI in the future. And we were working with one of our partners to produce a document on that. And we reflected on that and said, do you know what would be great? Is if we got the national cancer control planners together. A single meeting, just pulled them all in, because it's never happened before that we were aware of. And we felt that maybe there would be an interest in doing that. So we set about talking to our colleagues in IARC, WHO, and IEA, saying, look, is this something that you could support as well? Because it's important to have the UN agencies behind the work that we do at UICC. They were very supportive. I think we sent out something like 48 invitations to 48 countries, and we got 38 saying yes straight away.
Wow.
straight away. So they came to Geneva, and they came when the ambition of the event was really for them to get to know each other, but also to cover the full aspects of national cancer control planning and hear from them where they were struggling at a national level on aspects of either writing or funding or implementing or measuring progress on a national cancer control plan. And for 3 days nearly, it was 2.5 days, we brought in 44 individuals involved in cancer control planning from 40 countries. And we also brought in 50 players from our community, including the UN agencies. And through roundtable discussions over 2.5 days, we all became well informed on the practical issues that they were facing at a national level and what we could do to help them. Now, the interesting thing is the feedback was so strong that we, at the UIC board, we decided that we would do a second one next year. We announced last week that we're doing a second one with another 40 countries.
An additional 40 countries?
An additional 40 countries. That means 80 countries will have gone through a national cancer control planning, a cancer planners forum over a 12-month period. We'll do the same format. We'll bring in all the key players. And the beauty of it is that we've created these networks of self-help. We've got different organizations working with different countries now. The doors have been opened through WhatsApp groups in Africa, for example. We've benefited by understanding exactly where people are on their cancer control planning, what the issues are they have. And also the interesting thing is that WHO, our colleagues at WHO, have also last week said that they're going to start building in their training program plans for national cancer control planning around the Cancer Planners Forum, with 2 virtual dialogues taking place before the event, and then ongoing training through the WHO Academy. Now, this all started literally with a whiteboard just over a year ago, and now we're working closely with national cancer control planners around the world. We'll have 80 of them done by the end of May.
That's fantastic. Congratulations on that work. And,
Thank you.
You should be applauded for that effort, by the way. And you cited a few, but maybe you could highlight some real-world barriers to implementation. And you brought up a couple. We were talking about a few earlier: data gaps, workforce shortages, financing constraints. All of the above. What are the priority issues that were raised?
Well, all of the above, you said there. I mean, in fact, Dorothy's here. Dorothy Keefe's coming on the panel in a moment, and she was at the Cancer Planners Forum, and she articulated all of those from a high-income country. So you imagine what it's like in a lower middle-income country where you don't have necessarily the political will to put in place a plan over the longer term and fund it appropriately. But the normal challenges that we see, and they were reiterated at this particular forum, was political will. You've got to have political will. And that political will has got to go through different governments. It can't be political will for government A, then government B comes in and throws it out again. So it's got to be political will, which I'd say more it's a country will, that there's got to be something done with cancer in a population that's growing and aging. Second thing is there has to be some sort of funding mechanism for the majority of the challenges in cancer control. And for those of you unfamiliar with cancer control, that's prevention, early detection, treatment, and care. It's not just about chemotherapy, it's not about radiotherapy, it's about prevention as well. And more often than not, funding is found for treatment, primary health care, and tertiary care. It's found for that in many countries. It may not be at the level that we really require, but it's found. Very little is allocated prevention, and that's one of the big issues. The risk factors of tobacco control, that's not really picked up in most plans in terms of funding activity and prevention or education of the general population on the risk factors for cancer. So those things come out. And then, of course, there's the ability to implement. As we know, there are lots of plans out there, and they've improved in the last 10 years. We did a review of all plans in 2018 through the International Cancer Control Partnership, and we did one which was published in Lancet Oncology this year based on 23-24 data. And what we saw was, if you take financing, for example, there's been a massive increase from 7% of the plans having a financing structure, actually detailed within the plan itself, up to 27%, which we can say that, well, that's good. But that means 70% don't have any mention of financing whatsoever in there. And of course, it's not that we expect cancer to be financed as a silo, but we would like to obviously make sure that it's included in broader healthcare investment and also UHC, universal health coverage. So it doesn't necessarily have to be a standalone funding model. It can be integrated within other approaches.
If we could dig into that for a moment, because you've mentioned financing a bit now, what are the innovations in funding models or partnerships you see that will be sustainable going forward for these plans?
I'm not a great fan of the word innovation when it comes to funding. I'm a banker for 24 years. All right, the basics of a health system have got to be taxation or insurance or both. I mean, that's it. And that's the bulk of the money that needs to be raised. And we can talk about innovation like social impact bonds and things like that, but
not going to make a dent.
Not going to make a dent. And actually, even taxation of tobacco is really important, but in the context of the total income received by a government, it's very small. But it's important because it sends a signal that tobacco is bad for you and it reduces costs in healthcare over time. However, at a global level, given the slight problems we're having globally on global health funding at the moment, it's been really interesting to see new ideas emerge. I mean, it's countries stepping up and more willing to do bilateral arrangements. Australia, for example, with Indonesia, and I know the German government is looking at funding and supporting directly more countries. And there are others that seem to be stepping forward. So that global funding structure seems to be moving on.
How about public-private partnerships?
That's an interesting one because even in high-income countries, you've got 30% of the healthcare services were provided by the private sector anyway. And when you go into low-income countries, it's probably 60%, 70%. So exists public-private partnerships that are in place today.
Yeah.
But whether or not they can do more, then I hope they would do, particularly in cancer treatment and care, where you need so much infrastructure at a cancer treatment centre, including radiotherapy machines, etc. There must be ways in which we can work more sensibly to get more capital, market capital, into the solutions.
Great. And by the way, quick commercial for the magazine that you found on your chairs. This issue of FP focuses on development finance and the fact that more needs to be done with less, and talks a lot about these issues, public-private partnerships, other types of efforts to raise funding and awareness and focus. So you hate innovation when it comes to finance. How about innovation when it comes to new tools, digital tools, AI? I have to say AI in every panel. That's a rule here at World Health Summit. What promising efforts do you see on that front?
And I'm not going to diss AI. Okay, so I think AI is going to be great for cancer in terms of medicine development, in terms of treatment that can be done remotely, drawing on best practice and advising and guiding, for example, on radiotherapy, et cetera, et cetera. I think it's going to be transforming, particularly on diagnostics, and we're seeing that already. The ability to diagnose a lung cancer through using AI is already proven to be better than the eye of someone who's looking at particular images. So I think it's going to transform the ability that we can treat. And we've seen that already. For example, in Geneva, where I'm based, we've got the Geneva Cancer Center there is actually providing support for pathology in Mongolia. And that came out of a World Cancer Congress meeting. And they're actually applying their AI system to recommend a treatment that should be used on particular cancer cases, which is fantastic because there's a shortage of pathologists all around the world.
Right.
So if we can use AI and remote to actually do pathology, that would solve a lot of our problems. Where I think there does need to be innovation, though, and certainly, when we talk about innovation, we do think about medicines and technology and diagnostics. I think there needs to be innovation in business models. All right. And one of the things that UICC has been pushing for the last 3 years is, can we think of different ways of creating commercial pathways so that companies like Pfizer and others can consider getting their medicines into countries in which they're not currently available. And we know that's a major issue in low and low middle income countries, particularly low and lower middle income countries, where less than 50% of the essential medicines list from WHO is in place. And that's the generics and biosimilars that have been around for years, let alone new medicines coming through which can transform the way that we can save people's lives on particular indications. So we've been working, a group of 42 organizations working with industry to create new commercial pathways under a coalition called the ATOM Coalition, Access to Oncology Medicines Coalition. And we've created 3 new pathways for the IDEA Foundation in Holland. And our colleagues from Medicine Patent Pool are in the room, have made available the first time. We've taken a voluntary license from a biopharma, and we are now delivering that generic version of that particular patented medicine into countries around the world. And thousands of patients are getting access to that. Now, that is innovation. Okay? It's innovation because at the end of the day, we're solving the problem that exists today, with current products and services by creating new business models.
Right. We could keep talking for a long time. We only have a very short period of time left, and we haven't touched on workforce. We haven't touched on equity. So we'll get back to some of this stuff later, I know. But let me finish with one question for you. Global health priorities often focus on pandemics and infectious diseases. And you and I were talking about this a little earlier. How can cancer and NCDs stay elevated and sustained as a top item in the international health and development agenda?
Well, I would say to some extent we have been and we are. I mean, we've had 4 high-level meetings in the UN. I think, hands up who was at the UN a couple of weeks ago for the NCD meeting, so quite a few of us were there. So that was the 4th high-level meeting on NCDs, which obviously includes cancer. And I've got to say the tone, the energy, the enthusiasm around NCDs and countries stepping up saying we're going to make this a problem we're going to solve was palpable. I mean, compared to 2018, which was pretty miserable meeting. I didn't enjoy it at all. But this was palpable. We also have regular WHO discussions on NCDs, cancer, lung health. We've got the cervical cancer elimination program being run out of WHO, being picked up around the world with countries like Sweden and Australia heading towards eliminating cervical cancer as a disease for women in the next 10 years or so, maybe even quicker in some countries. So I think we're in a situation where we have got good profile, but as we were saying earlier, we need momentum. We need momentum to keep it going, and that is the challenge. So the next high-level meeting is in 2031. There's a lot that can be done before then. Let's hope we don't have a pandemic in between. Let's hope, cross our fingers. And I think given the direction of travel on cancer control planning and the release of more funding into the problem, I think we're in the right track.
All right, good. That's a good up note to end on. Dr. Adams, I'd like to thank you for your insights and for kicking off today's conversations. Thank you so much. Round of applause for Dr. Adams. And I'd now like to hand over the discussion to my colleague, Allison Carlson. She's EVP of Research and Events at Foreign Policy, and she's going to lead a discussion on implementation and the role of national plans. Allison.
Thank you, Andrew, and thank you, Dr. Adams. That was a great start to the morning and to a very important conversation. We all know that addressing cancer and addressing national cancer control plans is not just for governments. It's a whole of government, whole of society challenge. And so this will take all of us. And I have the distinct pleasure now to dive into a conversation really looking at what are the roles also of other stakeholders from the multilateral organizations, private sector, civil society in this collective challenge and how we can work more effectively together to reach our common goals. So I would like to bring to the stage Dr. Alarcos Cieza, Head of Management and Non-Communicable Diseases at the Department of NCDs and Mental Health, the World Health Organization, Dr. Csaba Dégi, President of the European Cancer Organization, and Dr. Tim Wintermantel, Senior Principal, Global Public Health at IQVIA. Thank you for joining us. Thank you, everyone. Can you hear me? Okay, excellent. Thank you again for joining us today for this important conversation, and all of you for joining us in the room in a very busy week. So, Alarcos, I'd like to start with you. So as Dr. Adams mentioned previously, WHO has been collaborating with UICC on the Cancer Planners Forum, but I understand WHO is also developing a global cancer status report. Can you tell us a little bit more about that, whether national cancer plans will be incorporated, and really what the role of WHO is in this process?
Great, thank you. And yes, WHO is preparing this, the WHO Global Status Report that we will launch in 2026. It has been making for some time, and it's taking some effort because what we are doing is to really take a stock of where the cancer field is and what the future should be, or where we collectively should go moving forward. One of the things of this taking a stock means also to reflect of what have been successes so far. And of course, one of the successes is that so many countries, thanks to the collective effort of all partners, have national cancer control plans. And it is successes because, of course, that means already, only for the fact of having a cancer control plan, is that there are coalitions at country level that are working together for advocating and putting cancer into agenda. It demonstrates also a certain degree of political commitment, and also implies that there is thinking that you need to address cancer in a way that is a national level, at national level, and with concerted action at national level. But we have heard also from Cary that, of course, and probably everyone, based on all the work that has been done so far, knows there is still certain challenges that 27% of those cancer control plans are not budgeted, they're not so good implemented. So what we are learning and analyzing, not only from the experience of cancer, but we are also looking at other areas. Can we learn something also the successful implementation of plans, strategic plans from other areas where things are moving and that plans are implemented, whether it is control plans on respiratory diseases, whether it is on strategies on some infectious diseases, whether it is on rehabilitation. So we are looking also from that perspective. And we are thinking of, or identify so far, like 3 levers of fundamentals for success. The first one is that the plans need to be absolutely integral part of national health strategic plans. And it has been mentioned, they need to be budgeted, but what we need to push for is that they are budgeted as part of the national health strategy and not at a separate component that it is, even if it is related, but it is outside the national health strategy. So the fund or the budgeting and the monitoring and evaluation completely linked to the national health strategy is fundamental. The second one is, of course, that the national ownership is non-negotiable. And of course, the cancer strategy needs to be led by ministries of health, involving all the regional, all the relevant sectors, stakeholders, patients, health professionals. But also, stakeholders need to be from different sectors. If possible, stakeholders need to come from all different levels of government, national, subnational, and local. And what it is extremely important for success, bridging political parties. Because what we cannot afford, what is happening very often in many countries is, of course, is under a government, there is a cancer control plan with political will and enthusiasm, then if there are changes, that can change. So this bridge of political parties is absolutely fundamental. And actually, another point that is important for me to know, to make is that a plan needs to be linked to an operational planning, where there is concrete objective, concrete activities, concrete timelines, concrete monitoring mechanisms, and concrete stakeholders linked to each of these activities. because what we also see, and again, not unique of cancer, is that there is a lot of enthusiasm. All stakeholders want to contribute and move things forward, but they want to do it in its own terms. And then not everyone move with the same vision, the same objective, and then we cannot progress in the way we should. And the third is that the objectives, the plan, the operational planning needs to be tailored to the maturity of the system. Because otherwise, it will become only aspirational cancer control plans. If there is a certain maturity of the system, of course, you can start thinking of scaling up on innovation. But when there are very mature health systems, then it needs to be a very humble recognition what are the next steps that are absolutely needed, that will move the needle a little bit, and then only when I achieve that, I can move it forward. For that reason, measuring the capacity of the system in all the relevant building blocks of the health system, whether it is workforce, whether it is financing, whether it is health information system, is absolutely fundamental. It needs to be tailored to the maturity.
Thank you, Dr. Cieza. You raised so many important components of establishing a national cancer control plan, and then what is needed to, in fact, make it operational. And you raise also important points about making sure that while, if driven by the ministries of health, there really needs to be participation by and integration with subnational governments and also stakeholders to really enable that plan to move forward and to be operationalized. And you also mentioned political will. Dr. Dégi, I'd like to turn to you on that front. In Europe, there's certainly momentum as well with Europe's Beating Cancer Plan, the EU Cancer Mission. But I'm curious from your perspective and where you sit. We're also living in a dynamic environment. How would you characterize the political will for moving forward in Europe on national cancer control plans?
I think this is the core question, actually, because we are planning a new budget for Europe. And the health and the cancer budget, it's full with a lot of uncertainties after a very successful Europe's Beating Cancer Plan and Cancer Mission as well. So we have two mechanisms right now that are going to end by 2027. And then we have another 7-year budget in Europe. And now I think the biggest challenge we have is the long-term financing of the national cancer control plans. In my opinion, each plan, it's a kind of promise for the people who are affected by cancer. And plain and simple, advancing national cancer control plans will mean that we are delivering on this promise. And I think delivering means three things. Long-term financing, which is more than political will. It's political commitment. And here I think that even in USA, things are not so bad. There is still quite a high political commitment to the cancer as a burden, as a human burden. And I think that we can still build very much on that. The other issue is the issue of accountability. Most of these plans are indeed people-centered. But as you pointed out, and as we have analyzed from your database, from UICC and WHO, I'm very sorry to break the news, but most of them, they lack accountability. It's zero accountability. Honestly, how you can deliver a patient, people-centered approach perspective in national cancer control if you don't have any kind of accountability, any kind of common measurement that you use, and so on. And even the new instruments like the Global Cancer Fund that was launched in New York just 2 weeks ago, they will certainly have their value only if we succeed in speeding up a little bit the measurements, the accountability on the national cancer control plans. So we have a financing issue or challenge. We have a governance challenge on national cancer control plans. And as you just have started the day, our experience working in all of the countries across EU on a national level and indeed with the ownership of the countries, our experience is that this is a core issue and policy is becoming a larger and larger part of cancer care. So I am sure if you're representing cancer patients or any other kind of organizations, you have discovered in the last years that it's not just a cancer control plan, but it's also the fact that you need to upgrade yourselves and your mission with policy making, because indeed it has become a very crucial part of how we can deliver promise into reality. And the third question that was not touched upon yet here in our discussions is that only a quarter of the National Cancer Control Plan, globally speaking, has anything about survivorship planning. I am very sure you understand that in the 1960s, there was the Big C. The Big C in most of the countries, the luckiest countries, it's almost gone. But the Big C can return very easily because the statistical data and estimations shows us that cancer is increasing, especially certain types in certain age groups and so on. Focusing on survivorship, putting survivorship care in the front, it's non-negotiable. We have a huge problem with that in the national cancer control plans. And because you said we have to talk about AI anyways, I am just joking. I am very honest, in survivorship planning and including psychosocial support for people affected by cancer, AI can be, and it is, incredibly good. It was unexpected, even for those who are psychologists, that the systems can be so close to the people affected by cancer, and people affected by cancer embrace them on a very high level. And just an example, if you have seen the launch of the ChatGPT 5, you have seen there a patient, a survivor of cancer, telling about how AI helped her through her cancer pathway and everything. So I think this is the third challenge that is in the package.
Challenges and I think opportunities
Yeah.
to leverage technologies and other tools to really understand what interventions are driving impact and where resources can be most effectively allocated to address, this manifold and complex challenge. It strikes me the policy review from the Lancet that was mentioned was also looking at the degree to which national cancer control plans that are out there are evidence-based or even reference evidence-based decision-making, and there are relatively few. And I think that's also emblematic of the fact that, as has been already mentioned, there's a lack of data to really inform what kinds of interventions are driving the greatest impact. And so I'd like to, Dr. Wintermantel, bring you in from a private sector perspective and reflecting a bit on what has been discussed already. How are you thinking about this challenge, the ways that IQVIA and you're collaborating on national cancer control plans, and then this point about ways technology can be leveraged to really understand the challenge more granularly, to really direct interventions more effectively?
Now, thanks for the question, and actually thanks also for the very inspiring discussions up to here. Indeed, as a leading human data science and clinical research company, we're obviously, our mission is really to make sure that as many decisions as possible that affect population health are actually based on the right data and the right evidence. And therefore, while obviously my esteemed co-panelist and Dr. Adams have already lined out the holistic nature of cancer action plans, I would really like to advocate for the improvement of data infrastructure and the collection of data and the ability to perform research on a country-by-country level on cancer treatments, cancer epidemiology, treatment outcomes is really instrumental. So, for example, our teams have worked together with pharma manufacturers from the private sector in Indonesia to contribute to the National Cancer Action Plan there, and are currently working on refinements for example, breast cancer. And I'm really happy that in this plan, the topic around cancer registries and cancer research features rather prominently. We all have high hopes in AI, but the reality is that AI will only be powerful if we really get data from the on-the-ground reality. And if we can really feed it with the right data. And again, this will be key for both the incremental improvements that mean the world to cancer patients whose survival can be extended, but also for some of the transformational improvements. So, in addition to data, it's actually also the data around healthcare decision-making. It's also data enabling countries to participate in clinical trials and to identify patients ready to participate in clinical trials. Now, coming from the pharma industry, you might think a clinical trial might only deliver a drug 5, 10, 15 years down the line with a low probability of technical success. The reality is, and I've visited some of our trial sites in sub-Saharan Africa where we run trials in non-communicable diseases, that clinical trial activities already now strengthen healthcare systems and actually make hospitals more powerful to also treating patients in their day-to-day lives. So I would really advocate for a strong focus on data-driven decision-making, and also improving the data infrastructure as a means to allowing research, also enabling AI then to do the transformational wonders that we all hope it will. In terms of private sector contribution, and again, probably my two asks in addition to that is really one of openness. On the one hand, again, the Indonesia example shows that there are really excellent national cancer action plans coming about by government and private sector actors. So I've been in and around the pharmaceutical industry for about 20 years, actually started in this town, Berlin. And every pharmaceutical companies, including obviously our hosts today, that I have seen is really an amazing collection of amazingly well-trained people trying to develop new treatments. And I think governments and public sector actors are actually well advised to really engage with this this pool of really well-trained brains that can contribute to make a difference. And the other ask on openness that I would say, and I know that Dr. Adams and I have discussed this already over the last couple of months, we're focused on cancer, and that's right, but this should not mean ignoring and putting different silos. Okay, here's cancer, here's mental health, here's antimicrobial resistance, because those diseases affect and threaten the same people.
Very well said. And it does take a more comprehensive look and analysis to be able to understand how, in a very resource-constrained environment, can those resources be budgeted more effectively for impact at greater scale. Dr. Cieza, I'd like to come back to you and on this notion of data and systems and clinical trials. I know WHO has been working as well on data system strengthening for health system strengthening. I'm wondering if you could pick up on that a little bit, and from your and WHO's work, how you foresee that progressing and going forward, and what some of those platforms may be for information sharing, especially across countries, and particularly in an environment where we're facing issues of digital sovereignty, data fragmentation, and others, and particularly in an area of health with concerns of privacy and others. How are you and the WHO addressing that challenge?
Yeah, no, thank you. And actually, based on the points that have been mentioned, I think it comes spontaneously now to my mind. We need to really also to reflect on the data that we produce and what we learn from conducting the number of clinical trials that we conduct in cancer. So WHO recently published, because it has been work over 3 years, in Nature Medicines, a study on the clinical trials that has been conducted over the last 20 years. We are talking about 120,000 clinical studies and 90,000 clinical trials. And this means 4,000, so if we distribute it through the 20 years, that is more than 4,000 clinical trials every year. So it's also a reflection, and I think there needs to be a reflection. Are we really doing the right thing and investing in the right things when we conduct this? And is the balance right? Is really the balance right? So this research has also demonstrated certain blind spots. What are areas that we are looking too much in cancer research and where we are looking too little? That is an opportunity of strengthening the health system, but very often only in high-income countries with a little involvement of this research in low-income countries. So I think this reflection also from learning from that data that we produce is also important moving forward. And also, by the way, what this study has also enabled is to create a map where you have really across the world where these trials have been conducted, what was the focus, what were of course, the cancer, what were the patient involved, and so on. So I encourage you also to look in WHO webpage for this study. It requires really a lot of reflection, and sometimes it's the thinking, okay, in some areas, we need to go back to the basics. But in terms of data and collecting data in relation to cancer control plans, absolutely. So one of the things that WHO is now also developing with the collaboration with, of course, partners organizations and many other experts is a monitoring framework for cancer control plans. And this will be also launched at the beginning of 2026. And we hope also that this will bring a standardization in what are the indicators that are collected, so that also across cancer control plans, the relevant data, but also the data that is comparable across countries can be analyzed, and we can learn much more moving forward.
Great. Thank you for that. I think you referenced blind spots and how important that evidence is, not only to understand what's actually having an impact, but also what are we not seeing and what are the gaps. And Dr. Dégi, I'd like to come to you on that point. And with respect to the blind spots and with respect to the gaps, I know you're doing quite a bit of work on people-centered care. And across the studies and national cancer control plans thus far, that has, to a large degree, not been a major focal point. And so I'm wondering, in terms of our blind spots, what is front of mind for you and what's needed, as there is so much focus and momentum going forward? What needs to be done, and what do we all need to understand so that those blind spots aren't missed and that people actually become the focal point of the planning process?
That's a very important question. Most of the plans, if you read them, you will discover that they indeed are mentioning being people or patient-centered. I always like to say that people first, patient next, so I prefer to use people-centered. But the truth is that if we are not standing up to our workforce in cancer care, we are missing the point. People-centered care, it's not just about the patients. It's about everyone who is involved in the journey with cancer. And actually, we do have not so blind spot, but a very important spot that we are still trying to handle in a way with the workforce shortages in cancer care and also the quality of the workforce in cancer care, including problems with burnout, mental health, and so on. Actually, recently we have published in Lancet Oncology common standpoint together with the ASCO, COSA, and ICO on the role of, of everyone, of how can we support oncology workforce. So when we are talking about people-centered care in oncology, let's not forget also the workforce part of that. On the other side of the story, I was listening exactly to the words that you were using, that in a financially constrained environment. That's true. And it's true for many regions across the globe. But the first time we were, faced with this issue, I was starting, putting together, and I'm sure you had a lot of experience in this area and a lot of activity that you have carried out in Cancer Mission. And I realized that if you're looking back like 20 years or 30 years, then we realize pretty soon that this is a very resilient community. And when we have financial constraints, we still have one of our greatest assets as a cancer community, which is our collaborations and partnerships. The fact that this year cancer is, I think, one of the, as Cary mentioned, it's a really hot topic and it's really a global topic. I think the reason for that is that we really have one of the most precious assets and resources, which is our collaborations and partnerships. It might sound stupid, but it might be more important sometimes than the money that we can use or get. And the last thing I would like to share is that we also need, all these focuses and perspectives, but it's so important that to make it right with the data. I just want to join you in that, because what we see from the evidence is that those countries who have national cancer control plans, and they indeed have some kind of evidence, that evidence clearly shows that in those countries, plans are impacting cancer outcomes in a positive manner. So I could also say with other words that it means a plus for survivorship. I could use many different words, but I would stick to a more professional sounding words that it impacts positively the cancer outcomes. And I think that this is a fantastic thing that we need to deep dive into. So I think that's really important. And also in looking ahead, in advancing our agenda, it's important what you both said, that we need to put cancer all together with mental health, or also with other NCDs like cardiovascular, because in Europe now there is a big buzz on the cardiovascular plan. Why is it important? First of all, because it goes back to the being people-centered. Most of our patients, they do have all the needs on oncology, cardiology, mental health, and so on. But on the other hand, there is a possibility to learn. And maybe you won't like the way I will say it, but also a way to compare ourselves as a cancer community on how we are performing. May I kindly remind you that being a cardiac patient like 60 years ago was a death sentence. And cardiology now, it's like, it's a miracle nowadays. Yeah, oncology has progressed a lot. But again, It's just the needs that our patients also have, all these needs together. So I understand, and there is a need, and this is why at UN now we had such a great momentum, not the perfect, but such a great momentum. But on the other hand, it's also a way for us to, make sure that we are performing well together.
Absolutely. We're running close to the end of our time, but Dr. Wintermantel, I'd like to bring you back in. Dr. Dégi, you mentioned the workforce, and I think that is certainly relevant to addressing cancer, but also our healthcare system needs across the spectrum. And so turning back quickly to innovation and thinking about what can be prioritized now, and actually picking up on a question that we received from one of our viewers in advance of this event, was really wondering how can innovation and digital tools help the healthcare workforce and health delivery, especially in rural and underserved areas. And I'm curious from your perspective, and this is from actions to implementation, how you're seeing IQVIA and your partnerships really drive that forward.
You said we were short on time, right?
Short on time. So.
Apologies. No, to end on an optimistic note. What I've seen, for example, in sub-Saharan Africa around the digital leapfrogging potential, specifically when it came also to around capturing patient-level data, was actually amazing. I was asking, for example, in the when visiting a national cancer center in sub-Saharan Africa around their patient records, they were looking at me and saying, "Yeah, of course it's fully digital for the last 5 years." I said, "But what are about the outpatients that are somewhere inpatient in another hospital further down the road? Oh, we're using the same system; it's fully compatible. Why do you ask?" And I guess if you ask that same question in Berlin or in Basel or in Zurich or anywhere else, people would say, well, we have this system from the 1980s and then we have some paper records here and so. So there is a lot of potential for innovation. Again, notwithstanding questions around funding and others on digital tools, again, AI harbors a lot of potential, provided that the underlying data is actually collected, and it is collected, as you rightly said, also from the patients in need and not just from the ones that can afford it being collected. But having said that, obviously all those are efforts. And I think where we as a community, and sometimes I hate myself for saying it because I also think the clinical metrics that we have are very relevant, and they have withstood the test of time, and they've helped a lot of patients, and they've enabled a lot of progress. As a community, we also need to be able to talk to an increasing number of governments who are slightly illiterate or even hostile to the language of science, but who will still be able to understand the language of money. Yeah. And I think as a community, we'll need to be more able to make that point clearer, that these investments are worthwhile infinitely more than others.
Thank you for that. And as a matter of fact, another announcement, if you have the cards on your chairs, there's actually some analysis that we did with Pfizer, with FP Analytics, our research division, which is looking at exactly that, the returns to investing in cancer care. So much more to talk about. Thank you all for your expertise, Dr. Cieza, Dr. Dégi, and Dr. Wintermantel. Appreciate you being here with us today.
Thank you.
Fascinating discussion. Thank you for sharing and for ending on a high note. Do appreciate that, Dr. Tim. So around the world, we're going to talk about case studies now. Around the world, many countries have strong national cancer control plans, but the challenge is translating those plans into action. And I'm so pleased that we're going to be able to hear from some of the leaders of those national plans from Australia and Kenya. So I'm very proud to introduce Professor Dorothy Keefe, Chief Executive Officer of Cancer Australia, and Phoebe Ongadi, Executive Director of the Kenyan Network of Cancer Organizations, or KENCO, who are joining me on stage for a chat about what they're seeing and hearing. Okay, let's make sure our microphones are under our chins. I know this is a fun contraption. Can you hear us? Fabulous. How's everyone doing? Excellent. Thank you for joining us and staying with us. Let's see. So cancer controls sit at the kind of nexus of health systems, and we were just talking about financing and innovation as well. Would love to understand how countries balance all of this and prevention, early detection and treatment, especially when resources are limited. So Australia, perhaps Dorothy, we could start with you. It's seen as a leader in cancer control planning, a model for national cancer control. And almost 2 years ago, Australia implemented its national cancer control plan. Maybe you could just share with us some lessons learned over the course of the past 2 years. I might add that you're also the chairperson of the International Agency on Research on Cancer, which is celebrating its 60th year. So congratulations on that. Again, if you could share with us what Australia has learned.
Indeed, and thank you very much. I've been sitting here listening and checking against all of the comments people have made about what you need in your cancer plan, just to make sure we have ticked all the boxes. We're not doing too badly. We've learned a few things. I think the first thing we've learned is that the foundation of the plan on engagement with the entire community in the country was even more powerful than we realised. So we all knew that we could have sat down and written the plan in 6 weeks in the office. But we also knew that would be the wrong thing to do. So we included everyone. We asked everyone in Australia what they wanted in a plan, and we did workshops and visits and online and everything. And what they told us fundamentally was 3 things. They wanted their cancer found as early as possible, prevented or found as early as possible. They wanted the world's best treatment based on good research and data, and they wanted to be cared for. And the cared for goes across the entire cancer continuum to survivorship and or end-of-life care. So our plan goes across the entire continuum, centred on the patient. And then, as everyone knows, implementation is the hardest bit, and a plan is only as good as the implementation. So I made a bold statement at the beginning, which was that implementation was a responsibility of the entire sector, because I run a very small national agency that doesn't have the ability to influence into the states and territories and the local hospitals unless everyone wants to be with me.
Right.
So we issued an invitation to the sector to partner with us to implement the plan. And we had a list of actions that would get us to the 5-year point of the plan and a list of actions that would get us to 2. But we don't have actions to get us from 5 to 10 because, well, 2 reasons. One was we didn't have the energy to fill in those 5 years, but also we knew things would have changed. So we invited people to partner, and people have partnered. They want to do this. The sector is engaged because it was invited at the beginning. And we also said we want everyone to be able to see themselves and hear their voice in our plan. And because they can, they're engaged in the implementation. So
inclusion is one of the
inclusion is really important. That's right. I think actually something that hasn't been mentioned is leadership in implementation. And I think that having an agency like ours that takes responsibility for the implementation, I did say it was a partnership, but I've taken responsibility for leading that implementation, for reporting on that implementation. That has given people confidence. Servant leadership it is, not dictatorial leadership. It's I'm here to help you do this.
Hear, hear. And I see you nodding, Phoebe, so I'd love to hear your reflections on Kenya's experience. I just want to add, by the way, and to clarify, that Dorothy and Phoebe are meeting for the first time here today. We've talked about how there are efforts to, through UICC, bring people together, IARC, but there are still many connections that haven't yet been made and shared. So I meant to say that at the top, very pleased that we could facilitate those kind of learnings between you two and all of us today. So Kenya has made major strides in cancer awareness, screening, and infrastructure in recent years. What lessons can KENCO, as you call your organization, and its role as a national civil society champion in cancer advocacy share?
Thank you very much. And you've rightfully said, I was joking with my panelists yesterday, we are saying developed and developing country. So it's very interesting to have that on board. So KENCO, as you have rightfully put it, Kenya Network of Cancer Organization, has made major strides as far as advocacy is concerned. Since its inception of cancer advocacy by UICC in 2019, one of the major things that we did as an organization was the enactment, what we call the Cancer Control and Prevention Act of 2012, that brought establishment of the National Cancer Institute, or NCI Kenya. What the National Cancer Institute was an advocacy-led organization, and it is an arm of the government that coordinates cancer control in the country and ensures there is considerable budgetary allocation that goes to cancer. Another thing that KENCO has done as far as advocacy is concerned is on the pushing for the regionalization of the cancer centers across the country. So initially, in the early 2015s, there was only one main cancer center in the country, and that was the Kenyatta National Hospital. And of course, you can imagine against a population of 50 million people, that was not enough. So KENCO, through advocacy, pushed for enactment of the cancer regional centers that are now helping. And just one more thing that we have done as an, just to show that advocacy really works, especially if it is advocacy in partnership with the government, because how we see the government as a civil society, we do not see them as enemies. We see them as collaborators. And we have made sure that before any policy is done as far as cancer is concerned, that the civil society are on the table. Why we sit on the table for the policy formulation is so that we take collective accountability on those policy implementations. So we are at the center between the policy formulation and implementation to keep it on check. And just one more to add,
of course,
because I'm just fresh from running on the streets. We were running the streets of Nairobi 2 days ago, and now we were pushing the government to consider increasing what we call the budgetary allocation for cancer care in the country. So we sit with the government on the table at the civil society, as the civil society, but when those policies are lagging behind, or when cancer care is not given the attention that it needs, then we get to the streets that we did 2 days ago.
Excellent. You activate. I like that. I hear some mild applause. Feel free.
Thank you.
I might also point out another distinction, since you're saying developed and developing. You just mentioned the population of Kenya, 50 million. 50 million.
Yes.
Population of Australia,
26 or 27.
26. So
Yeah.
when talking with Dorothy, she actually, the framing with her was, I'm very keen to hear how a big country handles this. And also in terms of population spread and locations, and you just talked about geography. So a lot of cool things to unpack here. Dorothy, let's come back to you for a moment, if we could. Let's talk a little bit about that kind of, let's just call it equity, not regionalization. And how has the plan strengthened Australia's First Nations principles? If you could explain that for a moment.
Yes, indeed. So, I mean, as I hope everyone knows, Australia has the oldest continuous living civilization in the world, 60,000 years, which is an incredible length of time. And the First Nations population in Australia had its own science and medicine before Western arrival. It got completely bulldozed.
Annihilated.
And we are only just realizing in our infinitely, thick way that actually there was an enormous amount to it and it needed to be recognized. So when and there's a huge gap in cancer outcomes in Australia between First Nations people and non-Indigenous people. So in Australia, we like to say that if you're white, middle class and live in the city, you have a fabulous outcome. Anything that you have that isn't one of those reduces your survival. And of course, as everybody knows, regional and rural, LGBTIQ, mental health, prisons, extreme age in either direction, all of these things impact. But the overwhelming inequity is in First Nations. And a First Nations colleague of mine, Lisa Wapp, has just published an article through the Lowitja Institute, which is really well worth a read, which talks about the difference between co-design and faux design. And co-design is the proper way of working with Aboriginal leadership, Aboriginal partnership, reciprocity. There's a thing about, what's in this for me as opposed to what's in this for you, and data sovereignty. So there's an incredible need to sort of tone oneself down from one's, I grew up in England, so I get all the privileges in the world except the Y chromosome. But I've pretty much overcome that one, you'll understand. But, I have to tone myself down, because it isn't about me or what I think about how we should do this. It's about the needs of the community, the leadership of the community, the partnership with the community. And so we really went into this listening. My role is as an ally to Aboriginal and Torres Strait Islander people, and I have to sit and listen and think about what I can do to help enact that. So that was a major focus of the plan. The first 5 years action plan is a plan on a page. There are 46 different actions. 16 of them are primarily directed towards improving cancer outcomes for Aboriginal and Torres Strait Islander people, but all of them actually work for Aboriginal and Torres Strait Islander people. And the one on the top left, which had a few murmurs from various people when it came out there, is eliminate racism in the healthcare system. And colleagues from the Department of Health said to me, that's not your job. And I said, well, if it's not my job, whose job is it? If we don't do this, we won't improve outcomes. And so there's a lot of power in the way it's framed. And again, it has people on board.
Love that. Dorothy, I love those reflections and insights. And I'd love, Phoebe, again, I mentioned, I don't need to ask all the questions. Yeah. If you have any reflections on that. I didn't have one really focused on equity for you, but if you'd care to chime in on that, would love to hear your thoughts.
Thank you very much. As a country, we have been grappling with the issue of equity. If you look at Kenya, as you rightfully said, we are 50 million plus people. We are diagnosing cancer late, over 70%. Cancer being diagnosed at stage 3 and stage 4. That means survival rates is lower because the more advanced the disease, the difficulty it is to treat with curative agenda.
Right.
So we are saying that if Kenya can prioritize diagnostics, if it can sort the bottleneck of diagnostics, then it can rewrite the cancer equity story in 5 prongs. If you look at currently, patients are presenting to hospitals already with symptoms. That means that it is already advanced. That is one of the challenges. If that is handled, and that can be handled by looking at demystifying the stigma and the fear around it. And then the second issue that we are currently looking at is the skilled labor. We are a population of 50 million plus people, and the pathologies, for example, are less than 100. You can imagine less than 100 against a population of 50 million.
100 people.
100, less than 100. And so then another issue that we talked about to ensure that equity is addressed is the issues around healthcare financing. KENCO has been at the forefront of pushing for healthcare finances. If you look at our country's NCD budget, cancer only gets 10% of it, yet cancer is the number 3 leading cause of death. Cancer, for example, cervical cancer, 10 women, by the time we are done with today, 10 women will have died from cervical cancer. This is a cancer that can be prevented, can be treated, and can be assessed early, can be totally eliminated. So those are some of the issues around equity. And then we are saying if we address also the issue of reagents and also infrastructure. We have infrastructure, for example, most of the time they're down, and sometimes the reagents get depleted. We also have challenges of access to medication. So for us, addressing the issue of diagnostics will sort us out, because that will mean we get cancer early. Our country cannot afford late diagnosis. We are looking at 70% of population. Already the rates of treatment abandonment is too high. That is why we took people with lived experience and we entered parliament, and they sat down and they listened to us and they read our petition on the floor of the house. We are telling them cancer right now, everybody has a personal story. It is time that Kenya prioritizes cancer, and it is time that Africa prioritize cancer care.
Excellent. I love the energy. And everyone does have a personal cancer story in this room, most likely, as well as in Kenya. A couple of things there I wanted to unpack. Early detection, innovation. Maybe you could talk a little bit about how KENCO addresses and is embedding innovation in cancer prevention efforts. I think what you just referenced was more education and awareness. How about innovation?
Yeah, so innovation, I'll just look at 3 of them. We're looking at cervical cancer that is killing the women in Kenya. And as I said, 9 to 10 every 24 hours are dying from cervical cancer. So what KENCO is doing, the first thing is that we are supporting the government for the rollout of the single dose. And this is innovative because it was a research that was done by KEMRI, and they found that the single dose is as effective as the double dose. So it means any girl between 10 to 15, by the age of 15, they should have received the single dose vaccination. Now that comes as a challenge because these girls are in school, they are in grade 5, but also these girls, some of them are out of school. So the civil society comes in to look for those girls that are not in school, that are out of school, that need the single dose vaccination. So we do that, and also through awareness creation and demystifying and ensuring that there is adequate stakeholder involvement, especially where we have the bottlenecks. The single dose, the vaccine for HPV in Kenya had bottlenecks around religious leaders, had bottlenecks around the parents, and then a lot of stigma, misinformation around vaccine. Most people believe it will stop their girls from getting children, it will stop their girls from doing so many things. So we come in as the civil society to bridge that information by having, and also finally, I'd just like to mention about innovation. We also having what we call the ECHO program. This is the Africa Cancer Research and ECHO program, where we put together 22 African countries to share their community of practice, to share their best practice, the evidence base in the different countries, and KENCO is the hub coordinator of that.
Oh, outstanding. Great work. Dorothy, same question for you on innovation.
Wow. Yes. So innovation.
And in detection and prevention, principally.
Look, I mean, prevention and detection in Australia are really interesting because we have screening programs for the 4 major cancers now: cervical, bowel, breast, and lung. The most recent one is the lung cancer screening program that was rolled out on the 1st of July this year. And I loved what was said in the previous panel about the leapfrogging of technology. So this is the first national screening program in the digital era. We haven't had a new program for 16 years. So this one is based on digital innovation. So the people who are eligible for the program have a low-dose CT scan, which has computer-assisted diagnostics. So we've gone from having 2 radiologists reporting to 1 radiologist and a computer. And if they disagree, you get a second radiologist. But usually what happens is they don't disagree. So we're reducing the workforce need by doing that. The other thing that innovation in this program is that we've introduced structured reporting for radiology. It used, traditionally in countries where everything has sort of grown up over time, the radiologist can report a scan pretty much however they like. And we've tailored this program so that in order to get the reimbursement for the scan, they have to report it in a structured way that can be digitally captured and put into the screening register.
A little bit of stick rather than carrot.
Well, sort of both really. But it's introducing structured reporting by stealth, because obviously you want structured reporting for every radiology scan, but you've got to start somewhere.
Yeah.
So those are the sorts of innovations that we're bringing in. And if I could just say on the equity issue, we're focused on equity of outcomes, not equity of inputs. So you have to target the inputs to get the same outcomes for the people who don't currently have them. And that's a shift in thinking.
Interesting. We don't have a lot of time left, so it just strikes me thinking about this. Dorothy and Phoebe, can you share? There's all of this kind of cliche that the developing country can learn from the smaller developed country. So, Dorothy, could you share maybe something that you've picked up from what Phoebe said here today, and then in turn, Phoebe, what you've learned from Dorothy on stage today?
Look, we learn all the time. There is no conversation in cancer where you don't learn something from the person you're talking to or with, and it's about breaking down the silos completely. So I love the advocacy piece is really important, and I was reflecting on this actually after the high-level meeting the other week, it was the advocates that got breast cancer put back into the statement, because it had been in and out and various things had happened to it, but an advocacy group for breast cancer got that put back in. And so this idea of KENCO and the advocacy team being so powerful is really, really useful. We can't do anything unless the advocates are with us.
Very good. And how about for you, Phoebe?
Thank you very much. I was looking at the statistics for Australia. You're doing far much better as far as cancer is concerned. And seated here, I am linking it to the technology that you have in place for diagnosing cancer, and because you catch it pretty early and you catch it right the first time. For us, before you catch it, it's like a maze. Running through a maze. And then now you're looking at this woman, because our country, 70% of the population is from the rural area. It's only 30% that are in the urban that can easily access these urban centers. So this woman from the rural area making her way all the way to a cancer center in a town city, and then they're told the radio machine is down, pathologist is not on site, we cannot trace your sample, the machine has not been working, it is broken, your finances, your net, the cover is not able to cover that. So I'm thinking getting it early and getting it the right time can really improve the outcomes for cancer in any country. That's what I'm learning from Dorothy. Thank you so much.
Very good. So I learned a tremendous amount as well. So thanks to both of you. I hope you did as well, both online and in the room. Join me in thanking Dorothy and Phoebe for sharing their insights, please. Get back to the microphone. That was fantastic. Thank you so much for joining and listening in on that. I would now like to invite for some closing remarks. We've had some very good discussions here. To wrap it, Karin Tollefson, the Chief Oncology Medical Officer from Pfizer. Please, Karin, join me. Thanks so much. Fantastic. What do you think of the discussion so far, Karin?
Well,
hard act to follow.
It's really a little overwhelming to come up here following these really the experts and the people who are really making a difference right now. So we need to thank them for being here and for sharing their journeys and really sharing the experience, because it's the start of these conversations and it's the continuation of these conversations and showing up at meetings like this that I think are going to have the real impact.
Great. So I completely agree. So would love some insights for you. How would you characterize the current state of cancer care and how innovation can help shape the future?
Well, I think we heard a lot about how innovation is impacting it today. But I think sometimes we have to, before we look forward, we have to look back and think about how far we've come. And so if you think back 30 years ago, were we talking about eliminating cancer? I mean, that wasn't the conversation we were having. We heard earlier in the 60s, it was the big C, right? We have come so far, and I feel like we're at another precipice of a turning point. And so if you think we've got not only a deeper understanding of the science and the biology of the tumor microenvironment, we understand the genetics of cancer so much more, we're able to target therapy so much more. And then you bring in and couple that with the technology that's available to us. And the science and the technology coming together really are at a turning point. And so one thing, I know Pfizer, we've got a very industry-leading pipeline, and we're seeing how we can bring forward small molecules and ADCs and bispecifics and all of these new technologies and innovations in therapies. And then we think about how does that land in all of these countries around the globe, and how do you make these available to patients globally? And there's the need to drive access for them, but there's also having the infrastructure that we need to have in place to be able to take care of those patients and give them the treatment and give them the care that they need to be able to take the complex therapies that we're bringing forward. We're not necessarily simplifying cancer treatment. It's actually becoming maybe more complex with all of the options that we have. But the outcomes are the potential for the outcomes are so much improved. So we have to build that infrastructure to make sure that as we bring these therapies forward, that we really can do this in a safe and effective manner.
So that's fantastic and very promising. But there's a lot of talk, and we've discussed about commitments and focus. How do we translate? We've been talking about implementation. How do we translate that into action? All of these tools sound fantastic. What do we need to do to implement them?
Well, I was really encouraged to hear the focus on the NCCPs, because I think these control plans at the national level are going to be absolutely instrumental in moving this forward. I think it builds a roadmap of accountability, and I loved what we heard, that we heard the promise of these NCCPs offer for patients, but it also really puts an accountability for all of the key stakeholders for us to turn it into action. We've seen data that shows that these plans can actually have a difference and they can really improve outcomes. But the plans are not the same in each nation.
Right.
And I think we've got to address them individually and think about what are the key characteristics and elements that have to be there. We heard a lot about financing. That's an obvious one. You have to put the money there. You have to invest so that we can do the education, we can build the databases, that we can put the wraparound services that are necessary. So funding's important. But I think the thing that is really profound that I've been hearing today is that collaboration across these plans, right? It's that bringing together a global knowledge base and kind of setting the best practices internationally around what do we need to be doing. And these aren't cookie cutter plans. One plan, we heard just now, the developing country and the developed country, those plans aren't identical, but there's a lot of commonality in what those plans include. And there's a lot of learning that we can do and how we move those forward. So I think that's really, really going to be a very important technology or a very important feature to the plans, is that identifying those best practices. And then we can't do this without implementing metrics. And we heard about the long-term goals that we have, really trying to increase survivorship, increase the area under the curve for these patients, for their lives, really pushing out survival. But we've got to use those shorter-term surrogate markers to help, one, encourage us to continue to invest, and to help intervene if we're not making the movement that we need to make. I loved hearing about the cervical cancer metrics around vaccination, right? We know that you can eliminate some of these cancers if we intervene early. Are we moving the needle on smoking cessation? Are we seeing that change? If we're not, why would we expect that we're going to see long-term benefit for lung cancer patients outside of improved therapy? We need to get to the prevention and the diagnosis earlier. So where we can focus on prevention and put in place metrics that can give us short-term wins, then we can start to show the benefit that we're having and increase the funding. So it all comes together.
The funding, I think, I agree with you. The financing came through, the need for financing and new structures came through clearly, and that these all can't be implemented solely by taxation and the like. And maybe this is a discussion we need to be having at the IMF World Bank meetings and have some ministers of finance in the room. Are there any ministers of finance in the room? Probably not.
No.
So this is, and there's an ROI focus that needs to be taken on this. It's economic security, as we discussed earlier at the top. We talked also a lot about multi-stakeholder partnerships. Would love to hear from you a little bit about, and specifically when it comes to the trajectory of equitability and access to cancer. How is Pfizer partnering to enable access to equitable cancer treatment around the world?
No, I love this question, and we heard a lot about the patients who aren't getting equitable access to care. I mean, cancer doesn't discriminate, and it's a very sad reality, but it appears that healthcare does. And we need to remove that barrier. And it's a harsh reality, but if we dance around it and don't call it what it is, we won't address it. So one thing, we've got multiple programs that Pfizer's doing. We don't do it alone. We partner with UICC. We partner with Partners in Health. There's many organizations that we're collaborating with. But we have a few things that we're quite proud of. The Accord for a Healthier World. The Accord program is something that Pfizer is investing in, trying to seek out the 1.2 billion people that are in lower income countries and making sure they have access to the Pfizer medicines that we wholly own. And so Pfizer's committed to making our medicines available, our vaccines and our oncology medicines available in those eligible countries, because we know that if we're not moving our medicines into those locations, patients don't have a chance for care. But these oncology medicines that we're making available are in those cancers that are impacting most people. It's breast cancer, it's lung cancer, it's GI cancer treatments. But we, again, need that healthcare infrastructure for them to be able to administer these medicines, to be able to track these patients and make sure that they get these medicines in a safe and effective manner. So just putting the medicines out there doesn't answer the need. We heard a lot about survivorship. We start treating patients with these medicines, they need the care through the complex treatment. But then if they're living longer, how do we bring them back into the workforce? How are we providing them with the socioeconomic support that they need? So we've got, as we change the paradigm on survivorship, we also need to provide those services and support for those patients.
We heard a lot about workforce as well, health workforce
Absolutely.
also, which is really critical and key. You know, one thing that we were chatting about earlier was about mental health in this space, and it popped up a few times in conversations that we were having for families and how that's developed over time. I was wondering if you'd care to share your thoughts on that and how important that is.
Well, I do think a holistic approach to a patient is absolutely essential. And when you see in the developed nations, you really get multidisciplinary treatment teams. So when you're talking about a patient care team, you have someone who's addressing nutrition. You have someone who's taking a palliative approach to think about the long-term survival for these people. And you have mental health care professionals that are available to patients, right? So it's a team of people taking care of a patient. And that approach has got to be replicated elsewhere, because when it's fragmented, we really miss the opportunity to provide that holistic care. And we know that an approach with this multidisciplinary teams really do impact long-term survival. These aren't fundamentally obvious in the NCCPs right now. We talk about prevention, we talk about early diagnosis, we talk about treatment. It's that last piece of survivorship and the treatment and the care that goes around patients that is maybe less obvious. It's harder to measure the impact. So finding those surrogates and how we can show impact to patients and show that impact long term is going to take data. We heard about the need for data and the quality of data that we collect. We've got to be willing to find ways to break down barriers in data that can follow a patient, the continuity of care of a patient, so that we can show the impact of all of the multidisciplinary teams have on that patient.
Fantastic. Well, really insightful and a nice positive note to end on. I want to thank you, Karin and Pfizer, for helping to convene us all together with World Health Summit for this excellent discussion. Please join me in thanking Karin Tollefson.
Well, and thanks to you.
Pleasure. Thank you. So that concludes our programming today. It really, I just want to thank all of our speakers. I thought that was fantastic discussion, and for all of you for listening and participating and nodding along with the conversation and applauding. We've heard a lot over the past 90 minutes. We talked about how the fight against cancer is as much about systems as it is about science and will. We talked about execution and implementation. We talked about equity. We talked about the importance of financing and how partnerships are important. Government, civil society, the private sector all have roles to play. So if it's one conclusion that I'm taking away, that I hope you take away as well, it's that collaboration and sharing insights is integral to winning this battle across borders, across sectors. So that's going to move us from plans to action and implementation on the ground. I want to thank all of you for hopefully taking away from this conversation those same types of learnings to your organizations as well. So on behalf of WHS and Pfizer and Foreign Policy, I want to thank you for being part of this dialogue and the work you do every day to make cancer control not just a policy goal, but a lived experience. And I wanted to mention one last thing. Dorothy asked me to point out that these are on the back table. This is an invite to the May International Scientific Conference for the International Agency for Research on Cancer, their 60th anniversary. Pick up a copy on your way out. Thank you all.